I am Dr. Arpit from Sir Gangaram Hospital. I am presenting the case of Mr. KSY, 63-year-old gentleman, businessman by occupation and resident of Delhi. History is given by self and wife and seems to be reliable. Presented with chief complaints of fever with chills, pain abdomen since last 3 days. History of presenting illness. I would like to start my history from year 2000 when patient had an episode of pain abdomen which was diffuse, non-radiating, dull aching, for which patient visited the nearby doctor. On examination, he was told to have high BP and was started on a single antihypertensive drug. And also, on ultrasound, he was told to have large kidneys with multiple cysts along with cyst in liver. He was told to take one antihypertensive drug daily and also to do lifestyle changes, just including low salt diet and stopping smoking. At that time, patient used to smoke 2 packets of cigarette daily and used to drink one full bottle of whiskey on daily basis. He was non-compliant to treatment and did not change his lifestyle. In 2002, patient has an episode of one red-colored urine, which was associated with pain abdomen that was located in right flank, for which he visited his doctor and was told that his kidney size is increased and he had one of the cysts ruptured. After few days, patient again had pain abdomen in right flank, which was non-radiating, moderate, and it was associated with fever. Details of which exactly he doesn't remember, but he was admitted and told to have cyst infection. He received IV antibiotics. Duration again he didn't remember, but he took it for a long time. In the same admission, he was told that his creatinine is increasing and his BP is high. Patient was still non-compliant and continued with his usual lifestyle. As per patient, he remembers to have episodes of headache, pain abdomen, fever every 3 to 6 months, receiving IV antibiotics. Again, detail of each episode, patient could not remember clearly. But he told that despite not remembering the number, but he was at the end of the 2006, he was already on 4 antihypertensive drugs, and he was told that he is having his creatinine is increasing gradually. In 2007, he was told to undergo bilateral nephrectomy in view of repeated infections. But again, patient did not heed to the advice and had the same course over next 2 years. In 2009, he started noticing a decrease in urine output, swelling over lower limbs, decreased appetite, nausea and vomiting. At this time, he was told to start dialysis, but patient again refused. In the start of 2010, patient underwent bilateral nephrectomy due to repeated issues, and in the same the operation was done in the same setting, and the post-op period was uneventful. He was initiated on hemodialysis via a non-tunneled IgA catheter, and dialysis was done thrice weekly. There was no history of any volume overload, hypotension, or catheter-related infection at that time. Patient was simultaneously started on workup for kidney transplant. After 4 months, patient underwent a live, unrelated donor renal transplant, which was AB blood group to AB blood group. It went well, and patient was discharged with normal creatinine and on triple drug immunosuppression, namely cyclosporin, mycophenolate mofetil, prednisolone, and 2 antihypertensive drugs. After transplant, patient used to be compliant, and he also stopped smoking or taking alcohol. Patient had good urine output, normal renal functions with no evidence of any fever or infection, and was on regular follow-up till 2013. In 2013, his nephrologist told him that he is having increased creatinine, for which he need to undergo graft kidney biopsy. During the biopsy, the patient had massive hemorrhage post biopsy, and he was shifted to ICU. At that time, he received multiple blood transfusions as well as plasma transfusions. He received IV antibiotics, and as per patient, he has a total hospital stay of around 2 months. In the same admission, patient had an episode of anuria and was told to have clots, for which he underwent DJ stenting, and which was removed 1.5 months later. At the time of discharge, patient had a stable condition with a creatinine of 1.4 and was on same cyclosporin, mycophenolate mofetil, and prednisolone. At that time, patient did not have any proteinuria as per the history, and there were no further episodes of hematuria. Patient remained stable and continued with his medication until 2019 with no episode of any fever or rejection. When patient cyclosporin was stopped as part of the center practice and was continued on mycophenolate mofetil and steroid. In 2020, patient had complaints of generalized body ache, which was associated with swelling, distension of abdomen, which increased progressively and was associated with decreased appetite, weight loss. There was no history of any hematemesis, jaundice, blood in stools, breathing difficulty, chest pain, or chronic diarrhea at that point of time. On consultation with his doctor, he was found to have low hemoglobin and also told to have low protein levels in his body, for which he was admitted and worked up and was told to have large amount of protein in his urine. Patient received blood transfusion, albumin transfusion as well. His creatinine was around 1.8 at that time. On discharge, this time he was discharged at a creatinine of 1.8 and on tacrolimus, mycophenolate mofetil, and steroids. His BP was within normal range. Again, he received blood transfusions in the same year twice more times, and again patient had a history of abdominal distension and underwent ascitic tapping twice. In 2001, patient's urine output decreased. He had generalized swelling, again starting with abdominal distension first. He was started on toracimide and a patient was advised to undergo graft kidney biopsy again. Patient underwent graft kidney biopsy. Post biopsy was uneventful. Biopsy details are not remembered by the patient. He had repeated episodes of abdominal distension, for which he repeatedly underwent ascitic tapping. He kept losing protein in urine on regular tests, had decreased appetite and weight loss as well. On direct questioning, patient told that he underwent bone marrow biopsy and PET scan and was told that he is not having any abnormality on this. In view of decreasing weight and appetite and losing protein, his nephrologist told to restart on hemodialysis with the explained thing that patient urine output will decrease over time, graft will become dysfunctional, but his protein losing nature will be getting better. Patient did not give consent for the same, and he continued to receive blood transfusions again in October 22. After discussion and with patient's chair decision, finally in 2023 February, CAPD catheter was inserted. He was started on peritoneal dialysis 48 hours.
At that time?
Sir, 2.4.
2.4.
And he was started on peritoneal dialysis 48 hours after catheter insertion. As per he remembers, he was given 3 cycles, 2.5% of 2 liter each for 4 hours each. Patient had fever, pain abdomen, cloudy effluent, for which he got admitted in April 2023 and was told to have CAPD peritonitis, for which he received antibiotics for long duration. His exchanges were done by his caretaker. There is no history of any pet in house, and he used to follow proper hand hygiene, and there is no history of any wet contamination. In May, patient again had the cloudy effluent, but this time it was not associated with any pain abdomen or fever, and he was told at the time of discharge that his it is due to one of the antihypertensive drugs which was stopped, and this cloudy effluent resolved. Patient urine output decreased over the time, and his protein loss decreased as well. After this, patient changed his caretaker, and he again had an episode of fever and pain abdomen, and received intraperitoneal vancomycin, which was stopped almost after 3 weeks. And after this, his clinical parameters resolved. Now, the patient again has presented with fever, which was intermittent, 100 to 101 degree Fahrenheit, associated with chills. It was associated with abdominal pain, which was diffuse, dull aching, non-radiating, and it was not associated with any burning micturition, diarrhea, constipation, nausea, vomiting, cough, cold, altered sensorium, cloudy effluent, or decrease in BP. At present, patient is on CAPD, 2.5% 2 liters every 4 hourly with night drive, with total ultrafiltrate of 1.5 liter per day and urine output of around 400 ml. Presently, he is on prednisolone 5 mg along with erythropoietin and antihypertensives. In past history, patient does not have any history of diabetes, post-transplant diabetes, tuberculosis, coronary artery disease, or any CVE. Family history: his two brothers. He has two brothers, in which one has expired due to carcinoma throat, and other had renal disease. Other had polycystic kidney disease. He also have two sisters, which are both dead, and the reason is not known. Amongst his 4 children, 2 are affected, in which one is 45-year-old female who is hypertensive at present. Another is 40 years old male, again who is hypertensive and knows about the disease.
What is the age of patient?
So at present 63 years.
What is your diagnosis?
So my diagnosis is at present chronic kidney disease, transplant on peritoneal dialysis, chronic allograft nephropathy, live donor unrelated transplant, ABO compatible basic disease, autosomal dominant polycystic kidney disease, status post bilateral nephrectomy, hypertension, presently with CAPD peritonitis, and very chronic liver disease.
Very chronic liver disease. What is chronic allograft nephropathy?
Sir, chronic allograft nephropathy is the chronic graft failure, in which patient is having chronic changes in his allograft, which is interstitial fibrosis, tubular atrophy, can have transplant glomerulopathy. So
Is this term used nowadays?
no, sir.
Why are you using this term?
If interstitial fibrosis, tubular atrophy.
Chronic allograft nephropathy, this has been abundant since 2005. I don't think anybody in the world uses this term anymore. You can say chronic graft failure. If you don't know the biopsy report, you can say, because it is not clear, so I am not sure whether the graft failure, what could be the causes of graft failure in this patient?
Sir, again, the graft failure, first of all, sir, in 2019, initially, the patient had the insult, in which 2013 patient had this massive hemorrhage. So at that time, patient must have undergone ischemic nephropathy. Thereby,
Ischemic nephropathy?
sir, means patient must have gone under acute tubular necrosis
No,
due
but
to
that
hypoperfusion.
what his creatinine level was 1.4 after that.
Yes, sir.
So how it could
and,
be as that? That was
secondly-
getting post biopsy में surely
Yes, sir.
settled.
And then, sir, in 2019, patient's cyclosporin was stopped. That is one thing. Then, sir, there is
No, cyclosporin was stopped. Then what did it cause?
Sir, a patient may be having subclinical rejection or patient may be having sir, chronic ABMR undergoing. So both these things can be there. Donor was unrelated, sir. And, we don't know the HLA match as such. So that can be additional factor. Uh,
So that should have been clear on the biopsy. He underwent a biopsy in 2020 or 21 when.
21, sir.
So the doctor, his treating physician did not tell about the disease in the biopsy because there was proteinuria and there was blood dysfunction. The biopsy should have shown something, didn't it?
The patient does not remember, sir, exactly.
What is your guess? What could be the biopsy finding?
So with this much proteinuria, patient must be having say transplant glomerulopathy, or there can be uh, there can be already sclerotic kidneys. Then there is a possibility, but since the patient did not wasn't told about this and no history of any treatment, patient can have said de novo glomerular disease.
De novo glomerular disease.
Yes,
Like what?
like membranous.
Like membranous. So if there is a de novo glomerular disease like membranous nephropathy, then it should have been treated.
Well, sir, that's why I pointed out since the patient wasn't treated for the same, so unlikely, but we can keep the possibility for proteinuria at that time.
So you say because the patient cyclosporin was stopped and even in the related transplant, this was the unrelated transplant, stopping a CNI is going to lead to rejection in most of the patients. This was probably not correct, and then this patient developed blood dysfunction and because of the chronic rejection and then blood failure. But then I'm not sure why this patient developed recurrent anemia. Why would patient with graft dysfunction will develop severe anemia requiring blood transfusion and initiation of dialysis at creatinine of 2.4 means that is something. So are you sure about that?
Yes, sir. The patient received multiple blood transfusions, and on direct questioning, he told that he underwent bone marrow and he also underwent PET scan. There was nothing else.
What was the cause of? Could be the cause of anemia?
So, patient may be having chronic liver disease. Patient can be having associated hypersplenism. Patient can have pancytopenia due to that.
But that patient it underwent endoscopy or anything? Any
So he just heard about. I asked, but there was not. That's why I mentioned in history, sir. There was no history, no such history, but that can be one of the reasons.
That could be one of the reasons for this. So this patient was started on CAPD because of you said because he had proteinuria. That was the reason to start CAPD.
Sir, what patient told was the same. He was losing a large amount of protein in his urine, and day by day he was getting weaker. So he was told that it's better to restart on dialysis, be it HD or PD, so that his renal function is graft function is lost over a period of time, and so does the protein.
So that is the treatment. If you want to, if somebody is having, so what is the treatment if somebody has very severe nephrotic syndrome, like in kids and something? So starting a dialysis is the treatment for it.
So, but exactly the patient doesn't remember. In case, even in sir, if native kidneys, like if the patient is having severe proteinuria and that is having implications on the patient health status, so we can do that.
Why the patient with severe proteinuria develop weight loss? He can have it severe edema, anosarca, isn't it? Hypoalbuminemia, infections. Severe proteinuria can cause all these things. But severe proteinuria, if you see patient with membranous glomerulonephritis, proteinuria of 10 gram, 15 gram, do they lose weight?
Sir, but again, sir, there is an additional thing which is a part of chronic liver disease. So it's not a single thing that is ongoing. So patient may be having poor appetite along with it.
Patient could be uremic, maybe uremic plus because of the chronic liver disease. Did he have ascites?
Yes, sir, multiple times ascitic.
Yeah, so he had maybe he was losing weight. He had advanced kidney disease, which is not well reflected because of his poor muscle mass, and on top of that, he had chronic liver disease. And because of these two combinations, it might have been started on dialysis. Proteinuria is not the indication to start a dialysis. If patient is having severe proteinuria and that is causing all these complications, then you might consider either medical or surgical nephrectomy. How do you do medical nephrectomy in such a patient who have severe proteinuria, like kids who are having infantile nephrotic syndrome and they are losing large amount of protein and you cannot improve that because there is no treatment for that. What do you do? How do you
So
control that?
medically, diuretics plus NSAIDs can be used.
Diuretics? How do diuretics will help in proteinuria? Diuretics से कैसे proteinuria ठीक होगा? ये तो first
So
time
along with the non-steroidal anti-inflammatory drugs.
along with the non-steroidal anti-inflammatory drugs, along with NSAID, which will further kidney function will deteriorate. If the kidney function will deteriorate, urine output will go down, and patient proteinuria will decrease. Or you have to do an nephrectomy. But diuretic, how the diuretic will improve it? Diuretics will only increase the urine output. Diuretics को उसको नहीं ठीक कर सकते. So, but means it is very improbable. Means this patient, like if you see the course of this patient had graft loss because of the chronic rejection, because of the immunological reasons, which would be the most likely thing. So we don't know the biopsy report. And in chronic rejection, there is not so much proteinuria that it can lead to the other complication of malnutrition. This could only be possible if patient had kidney disease which is advanced, and chronic liver disease might be possible in this patient. And I don't know whether he had chronic liver disease or not. So why would you choose if the patient is having recurrent peritonitis? He is admitted 3 times or 4 times in the initiation of CAPD. So do you think it is the right treatment for it? What is the problem with CAPD if you put in a patient who has already malnutrition?
Sir, first of all, this was a shared decision for both by the patient and the physician.
No, that is fine. I am asking medically.
Yes, sir. In CAPD, there is a tendency to lose protein much more than dialysis, hemodialysis. So already in a malnourished patient, using peritoneal dialysis is a bit tricky.
Patient will only know whatever you tell him, unless he is curious, he is read, and he asks many people. Whatever doctor tells, patient will follow that. Would you start? Is there any particular reason for this patient to start CAPD or continue CAPD?
So patient was repeatedly having ascites. So and repeatedly was undergoing ascitic tapping. So one of the reasons. And obviously the patient wasn't ready to start with the hemodialysis again. So,
But now the patient is having recurrent peritonitis. Was this patient initiated on hemodialysis at any point of time?
just before the transplant.
Just okay, and still he is again admitted with fever. That could be peritonitis. We don't know that. Okay, so this patient had ADPKD as basic disease, so there is no confusion about it. He had multiple strong family. So what type of ADPKD he could have?
Sir, seeing the sir, probably he must be having a PKD1 mutation.
PKD1. Why?
Early onset of the disease, early renal failure.
Early onset. Early onset, this disease start at birth to everyone?
Means early presentation of the disease and large kidney and multiple cysts at the time of presentation itself. Renal failure at an age of around 50, 40.
So all the patients with PKD would have large kidney, and most of them. So what is the difference between the presentation in PKD1 and PKD2? And are there different phenotypes in PKD1 also?
Yes, sir. First of all, in PKD1 and PKD2, the PKD1 usually tends to have more cysts, larger cysts than early clinical presentation. The early tendency to reach to renal failure at around 50 to 55 years.
So all the patients with PKD1 will reach to ESRD by 50-55 years?
No, sir. So, there are some modifier genes that can lead to late presentation again when there is hypomorphia. So, in which the mutation, the patient is not having the truncating mutations. In that case, also patient can have late presentation.
What are the factors? So that's what I am asking. What are the factors which are responsible for the faster progression?
Sir, large kidney size more than 16.5, total kidney volume as per Mayo classification 1C to 1E, then pro-PKD score more than 6, male sex.
What is pro-PKD score?
Sir, pro-PKD score, sir, in that we take gender in which there is male sex is given 1 point, then there is urological presentation, any urological presentation less than 35 years, and hypertension less than 35 years. Other than that, these are the clinical parameters. Then the genetic parameters, either PKD1 or PKD2. PKD2, if it's there, it's given 0 point. PKD1, then truncating and non-truncating. So if non-truncating 2 points, truncating 4 points. If it's more than 6, high risk.
Okay, so this patient most likely could have PKD1 because he reached 2 years starting at the age of 50 years, and he had uncontrolled other risk factors, uncontrolled hypertension, smoking. All these factors are responsible for the faster progression. So this patient was started on cyclosporine, MMF, and steroids. So do you think that was right treatment? Means to sort of maintenance immunosuppression, or you would differ? With this patient, you would have transplanted this patient. Would you use the same immunosuppression or different?
So at present time, I would have used tacrolimus.
Even in 10 years back. Present time in 10 years is not different. 2010, 12, 13.
Yes, I would have started on tacrolimus, prednisone.
Tacrolimus. Why tacrolimus?
So, because studies says tacrolimus is better than cyclosporine in ways of rejection. Less rejection is with tacrolimus. Better immunosuppression with tacrolimus.
Any difference in rejection in graft outcome? Less rejection, but graft outcome. Say. Examination.
Patient is lying supine in bed and is conscious oriented to time, place, in person. Weight is 63 kgs, height is 185 centimeters with BMI of 18.4 kilogram per meter square. BP of 124 by 66 mm of Hg in right arm supine position, 126 by 66 mm of Hg in left arm supine. Uh, Pulse rate is 66 per minute, regular, normal volume, no radioradial, radiofemoral delay with no spatial character. Respiratory rate is 14 per minute, abdominal thoracic, regular. Temperature is 98.6 degree Fahrenheit, right axillary. Pallor present, ictus, cyanosis, clubbing, lymphadenopathy absent, edema absent, mild periorbital edema present. Per abdomen, on inspection, mildly distended abdomen, symmetric, midline scar extending from sternum to the pubic symphysis, probably a scar of bilateral nephrectomy done, with a PD catheter with dressing in left periumbilical area, with umbilicus moving equally with respiration, with normal hernia orifices, and the exit side is skin colored, inverted, smiling, with no space between catheter and skin. There is no erythema or any pus discharge. On palpation, inspectory findings were confirmed. There was temperature was normal, and there was no tenderness present. Patient refused for any PR examination, and genital examination as well. The on percussion, there was a dull note and auscultation. So, in other CNS, CVS, and respiratory findings are not possible.
Did you find anything like splenomegaly or anything?
No, sir.
So this patient has chronic liver disease?
Sir, because patient had repeated episodes of ascites and had this repeated blood transfusions, I kept as a differential diagnosis. Although I could not find, patient had this still, so I could not find any hepatomegaly as such.
Do you have any investigation of this patient? Now, how would you manage this patient?
Sir, presently first diagnosis being peritoneal, CAPD peritonitis. So at present, sir, I would like to, I will be evaluating the patient, will be sending the routines, complete blood count, renal function test, liver function test, and will be sending the culture of the CAPD along with the TLC and CAPD fluid along with TLC, DLC and culture and gram stain. Then blood culture as well, sir, and then I'll be starting with the intraperitoneal antibiotics since both gram positive and gram negative.
So this patient has any tenderness or cloudy fluid?
No, sir, not at all.
Why you start intraperitoneal antibiotic?
So patient has a repeated history of peritonitis, but
That is fine, but this time patient does not give any history of cloudy fluid or that is what, at least in the history, and there is no clear cut tenderness in it. So it does not mean if the patient has peritonitis previously.
so but patient actually when presented and when I examined, already he received antibiotics in between, so there is a possibility it was a resolving phase.
Could be possible, but then if we are not sure, so first you will start antibiotic and then you will confirm. If suppose there is this is a patient who is malnourished, he could have chest infection also.
But sir, the presentation was fever with pain abdominals.
Possibility is there, but then you have to prove it, then you will continue antibiotic. The patient is giving history of cloudy fluid. The patient has peritonitis, he would have cloudy fluid. Then you can directly start antibiotic. But he is not giving history of cloudy fluid. Then you will first see the fluid, and then if there is peritonitis, you will give antibiotic. So this patient had 4 episodes of CAPD peritonitis. Suppose this is also CAPD. Would you continue CAPD in this patient?
Sir, if the patient is having with the repeated gram positive bacteria, then I would first like to do away with the nasal carriage. And if the patient is having a different organism each time, then I would like to continue, but would ensure that patient gets a better training and has a proper set of precautions.
But the training should start with the first episode itself, not with the fourth episode. So, I think so. Anything else? Because there's nothing more to ask in this. So, because you don't have any biopsy findings and any reports and all that. So, difficult, and the diagnosis and basic disease is also clear. अगर कुछ किसी और को डिस्कस करना है तो बताओ. So anybody, anything?
So advising to shift to hemodialysis because of recurrent, as the patient had recurrent history of peritonitis, and so at this time advising him to shift to hemodialysis.
Yeah, I think it would be a better option because his blood pressure is still not very low. It's 120, 70 sort of that. I am not sure whether he really have chronic liver disease or not, because sometimes the ascites could be because of the poor inadequate dialysis and all that. That could be a possibility. So the patient tolerates, because he is obviously not a good candidate for CAPD. Recurrent, every month he is coming with, so this is probably a relapsing sort of peritonitis, or because 2 or 3 weeks he is treated, and then after stoppage within 2 weeks he is coming back with the infection. So it's not the ideal candidate for CAPD. Would you consider retransplant in this patient?
Yes, sir.
Consider retransplant. If suppose patient has chronic liver disease, then
So then we can proceed with combined liver
retransplant, if there is liver disease and combined liver retransplant, and this patient. Why this patient had severe recurrent anemia?
So that is one thing that was solved, but as patient told that there was nothing in PET scan or bone marrow as such. So there are two possibilities: either the patient is severely malnourished and having poor appetite, that it's nutritional severe anemia. Secondly, patient may be again having chronic liver disease associated hypercholenism, associated anemia.
Maybe patient was not taking his erythropoietin adequately.
Sir, he was started on erythropoietin later.
Because there is no history of bleeding, no history of hematomesis, melena, or anything in the. It could be possible he was not taking EPO adequately. And now, how is the hemoglobin?
Sir, last transfusion was done in October only. Thereafter, as per patient, he is being stable and didn't require any blood transfusion.
Maybe he was not taking erythropoietin properly. Otherwise, how will he respond? So, ठीक है, I think. Did you do genetic study in this patient?
I don't think so. Patient is already having that phenotype.
Suppose his son want to donate or kid want to donate. The age is 25 years. There are no cysts. In that case,
In that case, yes, I will proceed.
and 35 years and no cysts. In that case,
Again, sir, if patient is having, if is not having cyst, I would still want to do the genetic testing first before proceeding with transplantation.
What is the criteria for eligibility?
Sir, sonographic, ultrasonographic criteria is there, in which, in case if the family history is positive, then Reliance criteria can be used, in which up to 15 to 40 years, more than two cysts in
How many years?
15 to 40 years, 39 years, 25 to 39 years. If the patient is having more than equal to two cysts in one of the kidneys, then 40
One of the kidney, two cysts,
yes,
or one cyst in each kidney.
more than
25 years or 30 years?
25 years.
I don't remember, so I can't also.
15, not 30, 15 to 39, 15 to 39.
50 to 39, two cysts.
Yes. And 40 to 60 and more than 60. More than 64 cysts in, more than equal to 4 cysts in each kidney. 40 to 60, more than equal to 2 cysts in each kidney. And 15 to 39, more than equal to 2 cysts in one of the kidneys.
Even in one kidney.
Yes, sir.
This is an ultrasound or a CT scan?
Sir, ultrasound.
Ultrasound.
So in case we don't find any,
If patient, that's what I'm telling you, there's no cyst in kidney.
then sir, we must proceed with MRI of the.
So there are no cysts in kidney in MRI.
Sir, still, since the patient is young and the patient is having a strong family history, I would like to go for genetic testing prior to transplantation.
Less than 30 years of age. Like more than 30 years of age, there's no cyst even in MRI. The chances of getting PKT are not good. So what is someone done? Because you will have patient, they will have cyst. Less than 30 years, yes, you should definitely go for genetic study. More than 30 years, no cyst, I'm not sure. You can do for the safety purpose, but medically, it's thick. I think we have discussed most of the things.